actually evaluate that the patient needs surgery or not. Then, and of course, I usually put all my patients on 3 weeks of physiotherapy before surgery. And if I still feel that the patient, is not okay, or the pain is increasing by physiotherapy, then sometimes even I give a shot of steroid in the joint and see if the reduction of inflammation and pain may help the patient. But if after doing all that, I feel that, the patient still has symptoms, then basically, depending on the patient's own requirements, the age of the patients and other comorbid condition, etc., then I take a call on what's the best for him. Himanshu?
So you were talking about sometimes the laboral tear is 3 to 6, sometimes it's 6 to 9. So I'm just telling you the meaning of this thing. So we have two shoulders, and these things are based on clock dial mechanism. So if I am seeing this shoulder, then the 3 to 6 means the anterior labral is torn, which is the cause of instability or dislocation of shoulder. But the same 3 to 6 is posterior tear if I am checking on the left side. So this is important while seeing on the MRI. Is it the right shoulder or the left shoulder? So if there is a tear in anterior labrum, these are prone for dislocations, and these are the cases which may require surgery. And the posterior labral tear are those tears which are just because of bad biomechanics of shoulder, and those things can be treated by physiotherapy also. Next thing is adhesive capsulitis. So you asked that sometimes this is along with some tendinitis and partial tear. So either tendinitis can cause frozen shoulder or frozen shoulder cause tendinitis. So before treating them, you should know the etiology, that what comes first in the line. So most of the time when there is a primary adhesive capsulitis, there is adhesive capsulitis, and because of adhesive capsulitis, when we start doing physiotherapy, even after physiotherapy, the tendinitis can happen because the forceful physiotherapy is actually causing the impingement of supraspinatus tendon between these two bones. So in those cases, the glides are more important instead of giving forceful abduction. So by these things, we can easily know that what kind of protocol, and you are really doing very good in frozen shoulder, because I know that frozen shoulder is actually an entity of physiotherapist. Physiotherapists are the real doctor for frozen shoulder. Our roles comes only when patient is not able to do physiotherapy because of significant pain. In those kind of the cases, we infiltrate some steroid or dapamedrol or Kenacort kind of the thing to reduce that inflammation, so that patient can do physiotherapy in a better way.
So I just have one small input before we end up things, that since we were talking about the instability in this case, so one very small thing that I want to add on to give it to my budding physiotherapist, that there are certain exercises that are related to the proprioceptive drills of the shoulder. There are agility drills for the shoulders, because lot many physios or the patients who are coming to us, they are lacking into proprioception. Since because we are talking about the instability, we need to talk about the proprioception of that particular joint. And there are certain exercises that are built in with approximation and proprioception of the shoulder joint, which we should incorporate here to give it in an advanced phase rehabilitation. The second thing that I want to incorporate here is I take every shoulder condition as an instability only, because since even if we have a non-pathological, non-traumatic condition, if it's a slouch posture of the patient, so we have an overfiring pectoralis major which eventually pulls the humeral head anteriorly. And there has been an ultrasound guided study which has been done, that which says that in non-traumatic conditions also, if the pectoralis major is firing more, and if the humeral head is translated anteriorly in the glenoid fossa, it's a type of instability. So we can go for the length of the hamstring also, pectoralis major also. We can give glides, we call it as MWM, which we very commonly do, that's Mulligan's manual therapy. So we can relocate it within the shoulder, although it's not a subluxated condition, but it's a kind of position where you have abnormal pressure zones formation, which eventually can lead to other early degenerative changes here. So what I want to give an input here is about the proprioceptive and agility drills, which can be performed, of course, in the traumatic conditions, not treated operatively, and of course in post-operative patients and the conservative patients also. That's it. Thank you.
One thing I want to tell all of you, that shoulder physiotherapy doesn't, if a patient has been operated for shoulder instability and we are focusing on shoulder, it's not only the shoulder which is required the physiotherapy, because in throwing motion, the patient has to forcefully divert his kinetic energy from his toes, and then it goes to the trunk, and then he should be able to throw the thing, then only he can do the thing better. So it's very important. Sometimes the patient knows, sir, मेरा movement पूरी तरह आ गया है, मेरा ठीक है, क्या मुझे अब वाकई में फिजियोथेरेपी की ज़रूरत है कि अब तो मेरा सारा काम हो गया? No, you have not been treated well. You actually require something. Again, you should go to the physiotherapist. You should go work on some sports rehab. Then only the chances of dislocation can be reduced, because it's not only the labral injury, or it's not the only ACL injury which is the causing the instability in the joint. It is actually lack of proprioception. You have to again make some reflex in your brain that whenever your shoulder or your humeral head is coming out, your muscle should work again, and then they pull it back. And same thing is knee also. So in knee, most of the time we are focusing on quadricep strength, but the hams is actually the thing which is more important managing the ACL deficiency in the knee joint. So whenever this is not only the ACL ligament, which is the restriction for anterior drawer. So when the patient is playing, so it is important after ACL, why some ACL tear are torn again, and why some are doing so well even after 15 years. So this is actually in those patients where we have developed the proprioception in the joint, where we have balanced the knee in such a way that those reflexes are again re-established, they actually do well after the surgery. So that's why the role of physiotherapy is not only till the gaining the movements or gaining the strength. It's up to the level where patient is able to do the sports with normal proficiency and competency.
Thank you, sir. Thank you so much. That was really wonderful session. I request our residents have some updations regarding the same shoulder and the knee. So they have recent evidences that they have put into. You can just tell it in a very short span.
Good evening, everyone. Thank you so much for your valuable words, sir. Myself, Dr. Drishti, that systemic review and meta-analysis, which belongs to first level of evidence category, was based on the patellofemoral pain syndrome. Findings of that review was strengthening of hip abductors and lateral rotators have beneficial therapeutic effect in improving knee pain and improving the both short and long term than conventional exercises of quad. Thank you.
Good evening, everyone. Myself, Dr. Pooja Sharma, and that randomized trial was based on reverse total shoulder arthroplasty, and intervention period was 12 weeks, and the finding of the study was early active rehabilitation that include deltoid mobilization and rotator cuff strengthening exercise was effective for improving range of motion, strength and function of the shoulder joint. Thank you.
Thank you. Thank you so much, all the panelists. Thank you so much for sparing your time. Thank you so much to the audience.
Thank you, presentees. Now I would like to request Dr. Lalit Modi, sir, and Dr. Abhishek Gupta, sir, to felicitate our panel of physiotherapists, Dr. Vikash Mathur, Dr. Bhubon Chatterjee, sir, Dr. Himanshu Mathur, sir.